Hello and welcome to KYSCO Oncology Voices, bringing you the latest in Kentucky cancer care. Happy 2026. I'm Dr. Andrew Hearn, a fellow at the University of Louisville, here for the Kentucky Society of Clinical Oncology, or KYSCO. KYSCO is a physician-led organization whose mission is to ensure the highest standard of cancer care in Kentucky through education and advocacy. It's a free membership organization, and if you are a cancer care professional in the state of Kentucky, we invite you to join our community. On this show, we bring you along for deep discussions with your oncology peers across the state of Kentucky to bring you the latest in the community, cancer education, and advocacy. It's a new year, and today, the latest on hepatic arterial infusion pump therapy and how that affects care in Kentucky. Dr. Brent Xia is a surgical oncologist with the St. Elizabeth Cancer Center. Thank you, Dr. Xia, for this discussion today.
Thanks, Andrew. I appreciate it. And I appreciate the opportunity. I want to thank the organization as well for this opportunity to talk about something that I think impacts all of us, especially in the state of Kentucky.
So, Dr. Xia, just for people who aren't aware of you in Kentucky, could you tell us a little bit about yourself?
Sure. So I'm a GI and hepatopancreatic biliary surgical oncologist at St. Elizabeth Healthcare, which is in northern Kentucky. We cover a population of about 500,000 patients. Just south of the Ohio River in the Cincinnati metropolitan. I did my training at University of Cincinnati for residency, and then I did my surgical oncology training at Moffitt Cancer Center down in Tampa, Florida. I'm now in my third year of practice outside of training.
Wonderful. Now, when did you start getting involved with this hepatic artery infusion therapy?
This was something that our center looked at from a multidisciplinary standpoint approximately a year and a half ago. We had early conversations about it between medical oncology, myself, the infusion suite, and we explored this opportunity. It took us about probably a good 8 months of meetings, make sure we had the right setup with the company that supplies the pump and the chemotherapy, and we just went live with it the past year in January of 2025.
That's amazing. So it sounds like it's a developing technology that's sort of hitting prime time now.
Yeah, absolutely. I think the early data was back in the 1980s, and majority of it came from Memorial Sloan Kettering and was pretty promising. The adoption outside of Memorial Sloan Kettering took time to take off, but starting in the 2000s, even in the last 10 years now, we've had about north of 80 plus centers in the world that are involved with this now, and we are now the one of only two centers in the whole state of Kentucky that perform these procedures and offer this service to patients.
That's amazing. That's such a great asset to have here in Kentucky. So thanks for what you do. Well, I thought it would be helpful to just kind of go through especially with newer technologies, just kind of understanding the who, what, when, where, why, and of course, how this therapy works out. So what patient population is this really designed for? Like, why is this technology come across in the first place?
Sure, yeah. So there's currently 2 FDA approvals for it. It's for patients with unresectable colorectal liver metastases, as well as in the adjuvant setting, resectable colorectal liver metastases, and also in unresectable intrahepatic cholangiocarcinomas. Particularly in Kentucky, we are a hotbed in the nation for rising cancer rates, especially colorectal cancer rates. As part of the Appalachian counties and northern Kentucky, we have one of the highest, not only rates, but also mortality rates when it comes to colorectal cancer. And what we know is that ultimately up to about 50% of patients will at some point in their lifetime develop colorectal liver metastases based on just the hematogenous way that these cancers spread through the portal venous system to the liver. And we've come a long way from a multidisciplinary standpoint in taking care of these patients, and we have better chemos now, we have better support, but ultimately, even with the best treatments where we can get these patients to surgery to remove their liver metastases, we know that it's almost up to a flip of a coin, 50%, 60% in their lifetime that these cancers will come back. And so, what we need to do is we need to have a more targeted therapy, a more durable therapy, and less toxic therapy, something that patients can stay on much longer than chemotherapy, which does have hepatotoxicity to it.
Perfect. Thank you for that. And so especially now, you mentioned the targeted therapy, a lot of times we use antibodies and things like that, but this is almost more of an anatomical targeting. Could you tell us a little bit about the pump itself and how it works?
Sure, yeah. So the pump is little bit bigger than a port pump that we're used to seeing. So it's about the size of a hockey puck. And what we do is at the time of surgery, whether it's standalone or at the time of when we do surgery to clear the liver of the metastatic disease, we place the pump with a catheter into the gastroduodenal artery. So we isolate that artery out. And what that allows us to do is specifically target blood flow to the liver and avoid blood flow to extrahepatic organs such as the stomach, the duodenum, the pancreas. And so what we're doing is we're taking advantage of the fact that tumors that metastasize to the liver are predominantly supplied by the hepatic artery versus normal liver tissue that's predominantly supplied up to 70% by the portal vein. And so by taking advantage of that, we are inserting in a catheter that allows us to feed in a drug called 5-FUDR or floxuridine, which is a metabolite that gets broken down and it has a short half-life. It's all metabolized by the liver, and so 99% of it's all taken up by the liver. And so that's targeting the tumors itself, and because up to 99% is processed by the liver, you have very little to none systemic effects compared to traditional chemo. And because of that metabolism, it allows us to give the concentration of chemo up to 400 times what we can give through intravenous route.
Wow. So I bet that, that allows us to have more intensive therapy in the liver, but also sparing, some of the effects of systemic therapy. Has this been mostly tested in, as older adults? Do they benefit from having that more localized therapy? Who really benefits from this therapy?
Yeah, that's a good question. So, I think ultimately all patients with colorectal liver metastases benefit from it. So the two settings I mentioned are resectable disease and unresectable disease. So with resectable disease, the data with chemo after we clear the liver tumors is pretty much, I don't think that the past literature has shown any benefit in further chemo. In fact, if anything, it's more of the chemotoxicity. And so by using this in an adjuvant setting, patients come in every 2 weeks, get it filled with the 5-FUDR along with dexamethasone to decrease the risk of any liver toxicity. And this can be done as long as necessary, ultimately up to years even, because what we know is that for patients we can continue to have hepatic disease-free survival, that ultimately also increases their overall survival. And then on the other hand, in patients with unresectable disease, what the studies from Memorial Sloan Kettering have shown is that up to 47% of these patients, almost 50%, we can convert to patients that can get surgery to clear the disease, which ultimately those patients do better than patients who can't get surgery because of the ability to essentially send them back to a disease-free state.
That's wonderful. So, I mean, you talked about, the adjuvant setting, so typically after surgery, and as well as the unresectable setting. So if a surgical oncology is not already on board, when should doctors consider referring their patients for consideration of this therapy?
Absolutely. I think, at any time a patient has, whether it's metachronous or synchronous colorectal metastases, this should be part of the process of referral to see if we can involve the hepatic arterial infusion pump, whether it's in the beginning or even after 4, 6, 8 months of treatment, because ultimately once we get past 8 months of treatment, we start seeing the hepatotoxicity of treatment, as well as the fact that sometimes there's a resistance to traditional chemos. And the beauty of this type of therapy, regional therapy, is that it can be used in combination with systemic chemotherapy. The caveat being, once we place these, we have to stop any type of VEGF inhibitors such as Avastin, bevacizumab, because of that risk of biliary toxicity in conjunction with the hepatic arterial infusion pump.
Wonderful. I mean, especially, one of the joys of being a fellow is getting to talk with, experts like yourself, as well as being on these tumor boards where you get to see there's a big interdisciplinary push. So for people who don't have, they may not have a surgical oncologist on their tumor board, what are some of the sort of patterns of referral? How should patients go about having these performed? I guess it kind of gets to the where question, right? Are there certain places in the state? You mentioned where, you're one of 2 places in the state. And so should you, refer first to the local surgical oncologist for evaluation, or head straight to one of these larger centers that can perform this procedure?
Sure. I think, again, I think that the benefit of practicing oncology nowadays is that we have so many good options now, and we have that multidisciplinary support between all these service lines to give the patients the best care possible. And to make sure that we have the best treatment strategies and we leave no stone unturned. And so, I think the best thing is to make sure to see one, if we need to seek a second opinion. And there are centers out there that perform these, and the best way is that there's a website where you can find an HI center near you within a 30 or 50 mile or 100-mile radius. And so ourselves in Northern Kentucky, we perform these. The University of Kentucky performs these, and so I think it does provide a great benefit to patients, their caregivers, to give it's another tool in our armatorium, certainly to help patients long term for these types of diseases that traditionally we have limited options once we exhausted first line therapies.
Absolutely. And thinking about patients who may have, travel concerns, speaking about being farther away from these centers, how close do patients need to be to a center that performs these procedures? What sort of precautions do they need to take?
Sure. Yeah, that's good. That's an excellent question. So to go over kind of how we choose the patient selection portion. So, patients that benefit most from these, they have to have limited or no extrahepatic disease. So predominantly the liver is the only site of disease, and that they may have had treatment for some period of time and we've shown disease stability. And so when I see these patients, I have to make sure that they have reasonable performance status. They have reasonable liver function. So no evidence of portal hypertension or even any social factors that might present hepatotoxicity, such as excess social drinking. All right. And the next thing I do is I go over the ins and outs of the pump itself. So there are some limitations to what patients can or cannot do after the pump is placed. The pump is traditionally it has a specific type of fluid inside that expands with the patient's own body temperature, and that's what drives the chemo to slowly be infused into the liver. And so we have to avoid any type of exogenous heating or cooling, whether it's skydiving or hot tubs or saunas or scuba diving. So those are things that certainly we have to tell patients about. And then we have to make sure that patients have the appropriate arterial anatomy for us to place this pump in. Probably about 85-90% have the traditional anatomy, where we have a gastroduodenal artery that goes up and it then becomes a proper hepatic artery that splits into a right and a left hepatic arterial branch, because we have to make sure that we are able to properly distribute this chemo throughout all lobes of the liver and avoid any type of extrahepatic perfusion so that we don't injure surrounding organs.
Wonderful. And you talked about sort of the intrahepatic metastases. Is there a particular cutoff for liver function, if you think it's from the tumor versus not from the tumor?
Yeah, that's a good question. So, we have some criteria when it comes to liver function tests. No more than 3 times the upper limit normal for AST, ALT. Total bilirubin needs to be less than 1.5. And then, of course, we need to make sure that these patients do not have any type of portal hypertension, thrombocytopenia, just because that we want to make sure that we don't we don't decompensate the liver. The other thing we look at certainly is ideally these patients have less than 70% tumor burden of the liver.
Okay. And then we talk about sort of the why. What is the level of evidence that we have behind this treatment right now? And have there been any recent studies to bolster this treatment modality?
Yeah, good question. So the traditional data was back from Memorial Sloan Kettering, and so that did show significant improvement in resectable disease, as well as in secondary analyses of unresectable disease conversion to the treatment. And certainly that's also been supported by a lot of retrospective studies from other institutions, multi-institutional studies. And now because we have more and more centers that are performing these, we have a cooperative group that we are trying to pull our data together. And there's even randomized trials now ongoing, the pump trials that look at in a setting of colorectal liver metastases, as well as intrahepatic cholangiocarcinoma.
Wonderful. I mean, talking about some of the actual, sort of maybe counseling or pre-counseling, of this treatment to your patients. How do you counsel your patients on what outcome you're hoping for?
Sure. Ultimately, the outcome is combining improved overall survival, improved disease-free survival, while maintaining quality of life. Mm-hmm. I think those are 3 important adjuncts that we have to address and make sure that we're not losing sight of any one of those 3. And so I think in the adjuvant setting, to decrease the risk of these coming back so that we don't, because ultimately patients will reach a limit of how much their body can tolerate more and more chemo or even more and more surgery. And same in the unresectable setting. When we look at look at what happens to the liver when we can't have control of disease that spreads there, a lot of times one of the risks is hepatic decompensation because these tumors grow and they cause obstruction or affect liver function, where now we limit their ability to receive other type of agents from that typically they would be candidates for. And so these are all ways that we can have control of the disease. And while best case scenario is to go for the cure, but if we can't, then at least go for control so that we can preserve quality of life as well as longevity.
Wonderful, thank you. And I think in this age of health insurance, debates and things like that, is the insurance coverage, is that ever an issue? What's sort of the level of financial toxicity for the patients?
That's never been an issue for us. Of the 5 pumps that we placed in this past year, all of them were approved. We did not have to even run a appeal at all.
Wow.
Again, these are FDA approved. We have not had any issues with that. I think this is a great option, a tool in our tool belt to offer patients who are living with colorectal liver metastases.
Wonderful. Yeah, that's wonderful to hear. Now, do you feel like there's enough knowledge, sort of awareness of this treatment modality, to the community oncologists who might be listening? What would be some advice or encouragement you might have for them?
Yeah, no, I think we still need to spread the word out there. I'd like to see more and more centers adopt these options, and certainly there's lots of room for cooperation. So whether they may come to 1 or 2 centers in the state that perform these, but once we place these pumps in, patients can still get their chemos locally. They don't have to necessarily travel, more than 15, 20, 30 minutes away. And there's even a network for how we can have these pumps filled with the 5-FUDR, the floxuridine, so that they don't have to travel to more than excess of 30 minutes to a center that fill these. There is a way that there's a separate company that can be contracted where they could even have providers come to their house to fill these pumps every 2 weeks so that the chemo gets put in and the pump is actually adequately filled and we don't run into any issues. So there is a way for us to kind of cooperate and take care of these patients together and avoid, as you mentioned, financial toxicity or even traveling excess time, miles from where these patients live.
Wonderful. Yeah, I mean it's great to hear that there's all that coordination, that you're able to have people come to your house to change that out. It's just the quality of life, both during and after treatment being a goal is something I'm hearing.
Yeah, no,
So,
absolutely.
what would be really for the trainees? Like, I think it's helpful whenever we have these interdisciplinary conversations. What's one thing that you wish medical oncologists sort of knew about what you do?
Sure, yeah. So, certainly I get excited talking about the nuts and bolts of the surgery aspect. And, back when this first came out back in the 70s, 80s, a lot of the complications were probably from the technical aspects of this. However, we've really refined this down to the point where even now, we in Northern Kentucky, we are performing and placing these pumps robotically through minimally invasive incisions. So we were actually, this past summer, we were the first center in the Cincinnati metropolitan, as well as the first center in the state of Kentucky to successfully place 2 of these pumps in through small incisions, no bigger than about 4 incisions, about 1 centimeter big. And the patients went home the next day, right? So we took a surgery where they traditionally had a laparotomy incision and they stayed in the hospital for 3-4 days for pain control and really for recovery, right? And we took it down to incisions that were no bigger than probably a robotic cholecystectomy plus the incision put the pump in. And so these patients recovered faster, they went home faster, they resumed returned to intended oncologic treatment faster. And certainly from when you speak of a financial toxicity standpoint, they went back to work faster. And so there was a minimal interruption in their day-to-day life, in their work life, in their social life. And so ultimately that's the goal, right? We want to be able to offer treatments that do not interrupt the oncologic therapy that we want the patients to get. Because otherwise, if there's a delay, you can imagine, there's a risk of rebound for tumor growth and et cetera. And so these are safe procedures. We can do them safely. We can do them with smaller incisions. These patients can go home faster. And again, we can coordinate so that these patients can be taken care of regardless of where they live in all corners or areas of Kentucky. They can have access to this treatment and still have the support from their home medical oncologist and to supervise their treatments and to make sure that they still have these options for regional therapies that before were only limited to areas, specialized centers that they had to travel or even fly to.
Yeah, that's amazing. Now, I'm really encouraged to hear just how much progress there's been in this area. You mentioned that the safety of the surgery itself has improved dramatically, with the minimally invasive aspect of things. What are some, other than bleeding, infection, what are some of the main side effects or concerns that patients should watch out for?
Sure. So whenever I tell patients about the pump itself, there's about a 3 to 4% biliary toxicity. So biliary stricture with the infusion of the chemotherapy, and so the 5-FUDR. And so those are labs that we have to monitor every 2 weeks when they come in for their pump fill, and we have to monitor the AST, their ALT, their OCK-phos, and their total bilirubin. And right now, in terms of the dosing of the medication with giving it with dexamethasone, the risk is pretty low. It's probably lower on the range of 1 to 2% in patients who never previously had any type of surgery to the liver, who are healthy. Certainly could be higher if they've had previous metastectomies to the liver or they've had previous liver-directed therapies. And so those are all things that we have to take into account when we sit down with patients and their caregivers and make sure that we can optimally treat them and minimize that risk. And certainly if biliary stricture does occur, if we catch it early, then we can mitigate all the effects of it and even decrease the dosing of the chemotherapy that we give through the pump. And then there's also technical aspects related to surgery itself. As you mentioned, besides traditional bleeding, infection, because we're dissecting these vessels that are, the gastroduodenal artery is about 3 to 4 millimeters big. And so we're dissecting these vessels out. We're clearing out all the small vessels that feed that can give extrahepatic perfusion to the stomach, to the pancreas, to the duodenum. And so, there's always vascular-related complications such as pseudoaneurysm, which is rare but can happen. And these are all things that we monitor in the perioperative period as well, and we make sure that the pump's in the right position. There's no issues getting the pump filled. And if there are some complications that occur, we can work with our interventional oncology colleagues to salvage the pump itself or salvage whatever complications can happen as a result of the pump.
Wonderful. All right. Well, let me try and see if I can summarize some of what we talked about as we just approach the end of our time. So as far as the hepatic artery infusion therapy, to the WHO, we're talking about, I guess, resectable and unresectable, like colorectal cancer with liver metastases, as well as intrahepatic cholangiocarcinoma, sort of that, mainly the idea of being confined, the disease being confined in the liver. It's an actual pump that goes into the hepatic artery. So anatomy is a variant that typically you're able to change out the chemotherapy every couple of weeks or so, even from being at home. But this can be considered both in the adjuvant setting as well as farther down the line if the disease elsewhere has been reduced, and it's an additional option for the intrahepatic disease. Happens to one of two places here in Kentucky, both UK and Mary and Elizabeth. And then really just patients benefit if they have these isolated or the intrahepatic disease that we can treat with higher doses of chemotherapy to improve survival, improve quality of life, that being the goal, of course. And how you mentioned that there was a website to search in addition to filling anything in. How do patients find these centers that are able to perform this pump infusion?
Sure. Yeah, absolutely. Let me just find that website real quick so I could give it to you on Google itself.
Oh, perfect. And then while you're thinking about that, just as a medical trainee, I couldn't get in front of somebody without asking, what piece of advice do you have for medical trainees? I'm thinking about a career in oncology, surgical oncology, and just cancer care in general.
Absolutely. So first for the website, if you just type in find in HAI Center in Google, you go to Entera Oncology's website, and you're just by putting in your zip code, they can give you within a radius all the centers that nearby that offer this treatment, surgically as well as medically. And again, a lot of times we can coordinate with local medical oncologists so that the treatments can happen without having to travel unnecessary miles after that. And then, one thing I forgot to mention, and I know we kind of focus more on colorectal liver metastases, but intrahepatic cholangiocarcinoma, right? These are rare cancers. There's only about a couple thousand a year in the U.S., and unfortunately, these cancers we can't screen for. So majority of times when we find patients with these, when they have symptoms, the tumor is what we call unresectable. And so this is a good option for these patients, because what we've known from traditional trials was that in unresectable cancers for intrahepatic cholangio, the survival is pretty low. We're looking at less than about, I would say, 6 to 8 months. But with the option of HAI pump treatment, as seen in previous trials, retrospectively and Memorial Sloan Kettering, we dramatically increased that up to even a range of 22, 29 months and more. And so again, it offers us another tool in that area of traditionally hard to treat tumors with limited first-line treatments. And that we even have more trials outgoing out there right now, randomized controlled trials with multi-institutions exploring this effect even more. And I think the message to the trainees out there, to our colleagues, is that this is a really exciting time in oncology to be able to work together, take care of patients, take care of areas that 10, 20, 30 years ago we had limited options in. And when you look at NCCN, and once they exhausted first-line therapies, then second-line options were certainly, the prognosis was less and less and less. And so to be able to take care of these patients and ultimately, one, get them to our ability to render them disease-free, that's certainly very rewarding. And even if we can't, to be able to project and prolong quality of life, quantity of life, I mean, this is where we are entering into a new territory here that of numbers and even overall survival Kaplan-Meier curves that previously we didn't even think about was possible more than 5, 10, 20 years ago. And so I think, just the limit here is there is no limit in terms of what we can achieve together and these traditionally hard to treat tumors and really come up with solutions here. And I'm excited for future trials exploring combination therapies with regional therapy to just be able to offer more to our patients.
Absolutely. Well, thank you, Dr. Xia. It really is an exciting time to be a fellow. It seems like there's always something around the corner, and something for this opportunity to talk with you and to give our listeners the latest in cancer care. Thank you, Dr. Xia. Thank you for your discussion today.
Absolutely. And I appreciate it. My pleasure.
Yeah, absolutely. And thank you to our listeners for following along with KYSCO Oncology Voices, a resource of KYSCO. We also we'll have some show notes for that website that Dr. Xia mentioned, as well as any additional information that might be pertinent. And we want to make sure that is there a topic you want to know more about, or legislation you like to discuss, or resources we're missing? Please let us know. You can drop us a line or send an email to blawrence@kisco-oncology.org. That is BLAWRENCE at KYSCO-oncology.org. Plus, to make sure to head to this episode show notes, like we mentioned, for more on what we discussed today, and tap the follow button in your podcast app or subscription or wherever this ends up, so you know when we drop new episodes. Join us next time for more. We'll see you then.